Good afternoon. My name is Deb Sabaris. I'd like to begin by acknowledging the lands on which we're meeting today. I'm on Wurundjeri land. I'm sure you're on beautiful Aboriginal lands around the state and possibly around Australia in joining us here today. I'd like to acknowledge elders past and present, elders from other cultures and emerging Aboriginal leadership. This is and always will be Aboriginal land. So today we're here for another exciting Tri-Peaks webinar. We are partnering with DHHS on this, so welcome Lisa Thompson, lovely to have you here. And this is an update of the first national study of child maltreatment in Australia. I'd like to acknowledge my colleagues from the Victorian Healthcare Association and the Victorian Alcohol and Drug Association who are the collaborators on our Tri-Peaks work. It's terrific to be working with you. Today's webinar is also supported by the Centre for Evaluation and Research Evidence at the Department of Health and Human Services, and we have Dr. Lisa Thompson joining me today. I'd like to thank the Department of Health and Human Services for lots of cross-promotion on this webinar, and I've seen it very, very well shared in LinkedIn. This is a Zoom webinar, so please use the chat and Q&A functions for your questions and comments. At the end, we hope we'll have time for Q&A. We don't always, because the content is so rich. If we don't, we'll make sure we take your questions away and get those answered. In today's webinar, Professor Ben Matthews and Professor Daryl Higgins will provide an update on the progress of the Australian Child Maltreatment Study 2019 to 2023. This is the first national study of the prevalence of all forms of child abuse and neglect, their associated mental and physical health outcomes through the lifespan and the burden of disease. Today's webinar will focus on the study's progress in 2020, including successful completion of all 5 phases of the pilot study, key pilot study outcomes, and the next steps in preparation for the main survey in 2021. Now to introduce our speakers. So Professor Ben Matthews is a research professor in the School of Law at Queensland University of Technology in Brisbane. He's also the director of the Multi-Facility Childhood Adversity Research Program. Professor Matthews is currently leading this particular study. He also provides technical advice to governments in multiple jurisdictions in Australia, and to the Government of Ireland and to members of the UK House of Lords. He's conducted 3 research projects for Australia's Royal Commission into institutional responses to child sexual abuse. Professor Daryl Higgins is with the Australian Catholic University. He commenced as the director of the Institute of Child Protection Studies in February 2017. Daryl's research focuses on public health approaches to protecting children and child-safe organisational strategies. A registered psychologist, Professor Higgins has been researching child abuse impacts and prevention, family violence and family functioning for 25 years. Professor Higgins is one of the chief investigators in this study. Now, without further ado, I'm going to hand over to my colleagues who are going to present for us today. Thank you so much, both of you.
Thank you very much, Deb, for that kind introduction, and thank you to the CECFW and to the DHHS for facilitating this conversation today. We're delighted to be able to talk about our study again, and we really appreciate the level of interest in our work, and we hope to keep on giving you updates as the study progresses. I'm just going to share my screen and hope that the technology works. I'm pretty sure it will. There we go. So hopefully you can see that front PowerPoint slide now.
Yes, it's all looking good, Ben.
Great, thank you. And I should mention that my partner in crime, Daryl, is with me here today, which it's always a great feeling to present with Daryl, and I'll switch to Daryl at a couple of points in the presentation. Before we begin, I'd like to acknowledge the traditional custodians of the lands on which we meet and pay our respects to community members and elders, past and present. And I should note that we have a large team conducting this study. We have 9 chief investigators, our project manager, Dr. Deevna Haslam, and Dr. Nikki Honey, who's the Senior Research Director of the Social Research Centre in Melbourne, And the SRC is our research partner on this work. So they are the folks who are actually conducting the interviews on our behalf. And so we have a very strong multidisciplinary and international team. And so this is really a joint effort on behalf of all of us. So just to give you a bit of an overview of the presentation today, I'll just give a little bit of background about why we need to study child maltreatment and its health outcomes. I'll give a very short summary of some preliminary work we did to inform our study, which was a systematic review done globally of prevalence studies done at the national level. And then we'll spend most of the time talking about the nature of our Australian Child Maltreatment Study, and we'll look at what kinds of prevalence data we're obtaining, what kinds of health data we're obtaining as well, and we'll give you an update on where we're at and then next steps. So first of all, just a few background points about why we should study child maltreatment, and I'm sure I'm preaching to the converted here, so I won't labour these points, but I think it is useful to always just mention some of the key background context here. We know that child maltreatment has massive significance for individuals, for families, for communities, for the whole society, and what's of particular interest to governments, of course, to the economy. We know that child maltreatment, from other studies done worldwide, is common and it is harmful. And when we're talking about child maltreatment, we're talking about the 5 forms of child maltreatment that are acknowledged today. So we're talking about physical abuse, sexual abuse, emotional abuse, sometimes called psychological abuse, neglect, and we're talking about exposure to domestic violence as well, which is a more recently recognised dimension of child maltreatment. We think it's important to study child maltreatment because it's a serious, serious phenomenon. It violates children's physical, psychological, and sometimes sexual integrity, and it's often endured repeatedly, so it's seldom just a single event. It's a breach of fundamental human rights of the most vulnerable individuals in our society. We also have a pretty good understanding from studies elsewhere that child maltreatment accounts for substantial proportions of psychological trauma in individuals and across society. So to give you just some data here, some estimates, there's good evidence that child maltreatment accounts for almost 1/4 of depression in females and about 1/7 of depression in males, 30% of anxiety in females and 20% in males, and 1/3 of all self-harm in females and almost 1/4 in males. So we can see just from those 3 conditions the grave effects of child maltreatment on individuals' lives. But if we go broader, if we look at the international policy community, we can also see that child maltreatment is taken increasingly seriously internationally. So the United Nations, through its Sustainable Development Goals, views child maltreatment as a major public health issue for the international community. And it actually aims to end child maltreatment and requires all national governments to report on their efforts to do so. So this is really a phenomenon that is now recognised internationally. It's front of mind, and governments at the national level are required to act and report on their efforts. We also know child maltreatment has a huge impact on broader social systems of care for children, including out-of-home care. And we can see from a recent report on government services that in terms of financial cost, and here we're just talking about cost to systems like child protection, out-of-home care, intensive family support, and family support services, we're talking about an annual single-year cost of over $5 billion to the nation, okay? And they're just immediate costs. So that's not counting downstream costs to individuals and to their health over the lifespan, which, as I'm about to show, are enormous. So we know that there's enormous and wide-ranging adverse health, behavioural and economic consequences to individuals and hence to society through the lifespan of various types of child maltreatment. So we know that in infancy there can be failure to thrive and impaired development, throughout life, there can be major mental health outcomes, often including depression, anxiety, PTSD, self-harm and suicidal ideation. We know there can also be physical health outcomes from strategies that people use to cope with their trauma, including eating disorders and obesity. We know that for kids who are experiencing maltreatment, it's obviously incredibly hard for them to focus at school and to do well at school. So there is a huge academic impact in terms of school performance, but also behavior at school. And this is often not given the attention it requires. This is a really important dimension of this context. Those academic impacts then have flow down or downstream consequences on economic achievement, employment, and welfare dependence. So we can see how the repercussions of maltreatment can reverberate through the lifespan. There can also be effects on adult relationships and re-victimization and intimate partner violence in adulthood, as well as intergenerational maltreatment, which I'll return to shortly. In terms of disease, so disease mechanisms, there can be long-term disease, again caused by people adopting reasonable coping mechanisms to deal with what they've experienced. So from smoking, alcohol and drug abuse, and from chronic stress. So we know from brain studies that child maltreatment actually impairs the structure and development of the brain. Okay, and this effectively affects daily function, but it also shortens life. So this is the level of evidence that some of the best neurocognitive and development studies have found now. In sum, we know that there is a lifelong disease burden with intergenerational effects that is caused by child maltreatment. But we also know that not every child is affected in the same way, and that this is related to various factors, including what types of experiences they have and what types of protective factors they might also have. But there is some fairly good evidence that kids who experience what we call multi-type maltreatment and polyvictimization tend to have the strongest effects. Now, at this point, I'm just going to refer us to Daryl, who is quite an expert in this field and has done some of the earliest work in Australia on this field. Daryl, would you like to chip in here?
Yeah, thanks, Ben. I think for me, this is one of the most exciting things about the study and the focus that we have with this work is to understand the context of how interrelated different forms of child maltreatment are. So from some of the work that, that I did 25 years ago, we were discovering in Australia and internationally, when you ask children, or in fact, when you ask adults retrospectively about their experiences, the typical experience is not of just simply one form of harm, but in fact experiencing harm across the different harm types. So that might be sexual abuse accompanied by emotional abuse, or neglect accompanied with physical abuse, etc. And when you ask comprehensively in a single study about those experiences and look at the outcomes that are associated, the greater the number of harm types that you have experienced, i.e. multi-type maltreatment, the more significant the negative consequences are in terms of, psychological or health outcomes. And similar work has been done in the US and internationally, led in part by David Finkelhor, who, as Ben mentioned, is on our team for this study, looking not only at harm types from parents or carers, but in fact harm from others, such as other children, or in fact more broadly community harm. And so he's referred to that concept as polyvictimization, and very similar outcomes there in terms of the greater the number of different harm types or victimization types, the more likely you are to have greater outcomes. So really this, I suppose, is a strong piece of the rationale for our study, which is to look comprehensively at all forms of child maltreatment, as well as a number of other forms of victimization, so that we can look not only at the separate contributions of these to different health outcomes, but to actually be able to document their interrelatedness, which will help with our understanding both of its prevalence, some of the separate and interconnected risk factors, but also to help drive our efforts from a policy and practice perspective in terms of both prevention and early intervention. Thanks, Ben.
Thank you, Daryl. It's so fortunate that we're able to draw on Daryl's work over such a long period and to have his direction of our study in this regard. I'll just finish this little section just by pointing to a quote from a few years ago from Martin Teicher, who's probably the leading brain scientist in this field. We can see that brain studies demonstrate the profound adverse effects on human development, and he's concluded that maltreatment-related childhood adversity is the leading preventable risk factor for mental illness and substance abuse. That's a very, very powerful conclusion. What I draw our attention to there is that not only is it the leading risk factor, but he's noted that it's preventable. And there's been other work from different studies that have also found this. So why then should we study prevalence? And here we can acknowledge that, okay, we have a pretty good understanding that maltreatment is quite common in society, but it's not enough to know or just have a feeling that it's common. We need better science than that. We need better data than that. Our public health responses to prevent child maltreatment and to identify it and respond best to it require much more detailed information. So public health responses about where and when our prevention approaches are best targeted require evidence about the prevalence of each of these types of maltreatment. But that's not enough either, because we need to know a little bit more than just the proportions of the population that experience certain types of maltreatment or multi-type maltreatment. We actually need to know about the characteristics of that abuse as well. So we need to know things like what's the frequent age of onset when this happens to children. Does it affect boys in the same way as girls, or in the same proportions? We need to know how severe the particular abuse is and its consequences. We need to know about its frequency. So how many times is it inflicted or over what duration in childhood? We need to know who it is, who's inflicting the maltreatment, and we need to know about other family factors as well. And all of this helps us to develop a much richer picture of risk profiles of children, and especially for those kids who are unfortunate enough to experience multi-type maltreatment or polyvictimization. Now in Australia, we need to study this because there's major gaps in the evidence base about the prevalence of each type of maltreatment and about its characteristics. We also need that data so that our country can report on the UN Sustainable Development Goals. And we need this evidence because currently we don't have it. So we do have some official or agency sources of data, but due to their limitations, they just really do represent the proverbial tip of the iceberg. And that's not a criticism of the data that these agencies collect. It's simply a function of the nature of what data they're capable of collecting. So I won't spend much time on this slide, but I'll just point to the fact that the Australian Institute of Health and Welfare does collate data from each state and territory about children in officially substantiated cases, that is after investigations by government agencies. And generally every year, that collation of data from each state and territory results in a finding that about 1% or slightly less than 1% of children in any given year are in substantiated cases of child maltreatment. But when we look at other population studies using national samples in Western countries that are broadly similar to Australia, we see a much, much higher yearly prevalence of child maltreatment. So for example, in David Finkelhor's 2015 study, he found 15% of people reported experiencing maltreatment in the prior year. Similarly, a study in the UK found a rate of 6%. Okay, so we know that the official data available to us at the moment is only the tip of the iceberg. And of course, it doesn't give us information about the characteristics of abuse either. What about health outcomes then? Why should we study these? Well, again, there's a major gap in the evidence base in Australia. So there hasn't been a comprehensive assessment of the health consequences of child maltreatment at the national level in this country. And again, we need this evidence to inform targeted prevention policy and clinical responses. Just some of the major evidence gaps that exist at the moment include gaps in the evidence about health consequences of emotional abuse and of exposure to domestic violence. And that's partly because those two types of maltreatment have seldom been researched, and their health effects have seldom been researched, and certainly at the national level. Earlier work done, and I'm talking internationally here, has tended to focus on sexual abuse and physical abuse. But these two types of maltreatment, we feel, are extremely important and have been under-researched. So they are two particularly strong contributions that this study will make. We also have a major evidence gap about the health consequences of multi-type abuse in terms of being informed by evidence at the national level. Another major evidence gap concerns the effect on health consequences of the developmental timing of the maltreatment. So here we can ask questions such as, does the experience of maltreatment in early childhood tend to produce worse outcomes or similar outcomes at different points in life compared with the experience of maltreatment later in childhood? And we think that's a very important question, both from a scientific perspective, but also from a policy perspective. Obviously, if we can determine which types and which risk profiles of maltreatment tend to produce the worst outcomes, then we can tailor or recommend that prevention approaches be tailored towards those even higher risk cases. What data is needed? Well, in sum, pretty much everything. And so we're trying to actually do close to everything we can do in this study. We need evidence about the prevalence of each type of maltreatment and of multi-type maltreatment. We also need evidence about the health consequences, and we're talking about mental health and physical health, both short-term, medium-term, and long-term over the lifespan of each of these types of maltreatment, as well as multi-type maltreatment. So our study is actually going to generate this data, and we hope and feel that this will be a major contribution for the nation. Just a very quick summary of a systematic review that we conducted. I won't dwell on this, but we did do a lot of preliminary work to inform this study. And one project we did was a scoping study for the Royal Commission about how best to do a national prevalence survey. But we also did a global systematic review and critical analysis of other national studies that have been done around the world. And this informed our approach because we looked at not only what they had done, but we looked at their strengths and limitations. We actually found that there's been relatively few studies done around the world. There's only been 30 national studies of all 5 or even 4 types of maltreatment. And only 2 studies had been done that obtained data from adults about their experience of maltreatment over their entire childhood up to age 18. So most studies that are done in this field are actually done with children who are still attending school. And as a result, they're only capable of obtaining information about those kids' experience of maltreatment up to their current age. So it might be, say, age 12, age 14, and so on. So there's a big limitation, even in the best work that's been done so far. We also found that there's a huge variation in methods that have been used. So there's different measures or different survey instruments that are used, and they have different strengths and limitations. And they're also administered in different ways. So sometimes they're administered through schools, sometimes through households, sometimes through CATI, which is computer-assisted telephone interview. Just a couple of key points here before I move on. These points are important. Even the best studies that have been done around the world use instruments that have strengths and limitations. And what I'm meaning here is that some types of maltreatment tend to be explored in more scientifically robust ways than others. And what we're talking here about is congruence of the questions with sound conceptual models of the type of maltreatment. I'll give you a simple example to try and demonstrate this. So some studies that have been done to measure the prevalence of child sexual abuse in their questions do not ask about non-contact sexual abuse. They only ask about contact sexual abuse. Obviously, that's going to give you quite a limited and arguably underestimated result about the prevalence of child sexual abuse, because those items are not congruent with strong conceptual models about what sexual abuse actually is. So what's been really important for our purposes is to do a very thorough, very comprehensive analysis of robust conceptual models of each of the 5 types of maltreatment to make sure that the questions we ask are actually going to accurately capture the true prevalence of these types of maltreatment, and they're not going to define these types of maltreatment too narrowly and therefore produce underestimates, but also they're not going to define the types of maltreatment too broadly or too vaguely and produce overestimates, which would be just as bad an outcome. So that's a very, very important part of this study, and we feel that our study is strong in this respect. I'll return to this point briefly later, but that's an important point to take away. Another key finding from this study was that very few studies asked follow-up questions about the characteristics of the maltreatment, such as the age of onset, who it was who'd inflicted the maltreatment, and how often it had happened. So that study enabled us to develop the approach that we've adopted in our study. I've pretty much covered that slide, so I'll move on now to talk about what we are doing in our study. So this is a study that's funded for 5 years by the National Health and Medical Research Council. We'd also like to very, very gratefully acknowledge some additional funding and contributions for the study provided by the Department of Prime Minister and Cabinet, the DSS, the Australian Institute of Criminology, and by QUT. We've really covered why the prevalence data in Australia is essential to capture. It's because we do not have this evidence base, and that without this evidence, we can't properly target our public health approaches. In terms of our broad aims, there are four broad aims. So first is to comprehensively examine the prevalence of each type of maltreatment and of multi-type abuse. Second is to identify information about the characteristics of these experiences. So to be able to disaggregate these experiences by child age, sex, timing, frequency, relationship to person inflicting the abuse, and to generate specific high-risk profiles. Third is to assess key mental health outcomes and physical health outcomes associated with maltreatment and its different patterns across the lifespan. And fourth is to estimate the burden of disease to the nation associated with maltreatment. In terms of the study design, just very briefly, it's a nationwide cross-sectional survey of approximately 10,000 people across the nation, aged 16 and over, and we're using computer-assisted telephone interviews to conduct the survey. In terms of the sample size, we'll have approximately 5,000 participants who are adolescents or young adults aged 16 to 24. And I'll just pause here for a moment and say that there's 2 reasons for this oversample of younger Australians. One reason is so that we'll have particularly strong information about relatively recent experiences of Australians in terms of Australian history. So we'll get a very strong, powerful picture of relatively recent experiences of child maltreatment. Second is so that we are equipped to conduct further subsequent studies with a cohort from that group. So one thing that we're doing is we're asking participants, or we will be asking participants, if they'd be willing to be recontacted in case we're able to conduct further studies. This is something that we'd like to do. And so if we can obtain consent from a group of those participants to participate in further studies, we may be able to track them over a longer period of life to explore further consequences and further behaviours and outcomes that they may experience over life. So that's a really exciting prospect, which is a second part of the reason for that oversample. In terms of the other half of the sample, we'll have 1,000 adults in each of 5 age strata, which are 10-year age strata. So 25 to 34, 35 to 44, 45 to 54, 55 to 64, and 65 and over. And the reason for having these participants is so that we can assess 2 things. One, we can assess the experiences of people's experiences of maltreatment at different points in Australian society, in Australian history. But also, and perhaps more importantly, we can assess health outcomes of child maltreatment in midlife, but also even through to older age. So we can assess health outcomes through the lifespan and get a much better understanding of their nature and their gravity. This study actually asks people to provide self-report information about their experiences. So we ask them questions about certain types of experiences, and they pretty much answer yes or no about particular things that they may have experienced. So obviously a lot of people will be saying no to certain things, but we'll be able to obtain information from the horse's mouth, so to speak, about what their experiences were. But we also obtain diagnostic information about mental health outcomes and other information about physical health and behaviours. There are other parts to the survey, and you can probably tell that this is quite a long survey, but it's important for us to obtain information about other adversities as well. So we do ask questions about, for example, peer bullying and sibling violence, and we do ask about other adversities or adverse childhood experiences. These are important in their own right, and to be able to estimate polyvictimization, but they're also important for us to be able to accommodate as confounders in our analyses. And so this study is important as a benchmark study in itself, but it also lays the foundation for further essential studies, including the possibility of examining intergenerational effects. In terms of the sampling frame, it will be nationally representative of people aged 16 years and over, accessible by mobile phones. We're accessing people through random digit dialing. People will receive a pre-approach text message to let them know that they'll be contacted, to let them know that this is a legitimate authorised study funded by the NHMRC, and that's part of a strategy to increase the response rate. As I mentioned earlier, the Social Research Centre is our partner organisation. They are highly experienced in conducting national sensitive interviews. They have highly trained telephone interviewers, but we conduct further intensive training with them to let them know line by line of our survey instrument how it needs to be conducted and the nature of the study generally. And we also have embedded measures to provide them with special support and monitoring and quality assurance. Just a couple of notes about what we're actually asking in this study. So we're asking about experiences of all 5 types of maltreatment across childhood up to age 18. So we're asking about physical abuse, and that's by parents and caregivers, sexual abuse by anybody, emotional abuse by parents and caregivers, neglect by parents and caregivers, and exposure to domestic violence, as well as those other key adversities. And just to note that we do have some 16 and 17-year-olds in our youth and young adult cohort. Those 16 and 17-year-olds will also be asked about their experiences in the past year if they say yes, they've experienced any type of maltreatment. In terms of the instrument, the survey instrument we're using, we are using an adapted version of an instrument called the Juvenile Victimization Questionnaire, which is David Finkelhor's instrument. We judged this to be the best available instrument to suit our study purposes, and indeed any study in this field. It has proven use. It includes follow-up questions of the kind we generally need. And it's generally practicable in terms of time and cost to administer and minimize missing data. However, we have engaged in a very detailed process of further developing and configuring this instrument just for this study. And this has taken, probably a good 12 months of work. And you can probably hear me kind of smiling, and Daryl, I'm sure, is smiling at the same time, because this has taken an incredible amount of very detailed technical work, but it's been essential and it's been worthwhile. So we've modified this instrument to ensure that our maltreatment questions meet our study aims, that they comprehensively measure each of the 5 types of maltreatment, that they are congruent with those robust conceptual models of each maltreatment type that I mentioned earlier, and that it's linguistically and culturally suited to our Australian setting. We've then tested our instrument. So we've done conceptual analysis. We've subjected our draft to independent feedback by technical experts all over the world. And we've done cognitive testing in Melbourne and with abuse survivors and youth. We've then done a full pilot test with 100 people, plus a retest 3 to 4 weeks after, and various types of analysis of the pilot data. I'll just mention before moving on that we have essentially 20 questions about different manifestations of maltreatment. And these questions are called screener questions. They're behaviourally specific questions which ask essentially yes/no questions about whether a certain kind of experience happened, or whether a certain kind of event happened. So I'll just read one out for you so you get an understanding of how this kind of goes. So one of the emotional abuse questions reads, did any of your parents insult you, humiliate you, or call you hurtful names? So we've tried to observe best practice in survey question design to make these questions quite simple yes/no questions that are behaviourally specific rather than abstract. In terms of those 5 dimensions of maltreatment, we have 2 questions on physical abuse and 1 item on corporal punishment, 5 on sexual abuse, plus 2 on internet sexual victimization, 3 on emotional abuse and neglect, and 4 on exposure to domestic violence. If someone says yes to any of those questions, they then receive some follow-up questions which enable us to gather information about the characteristics of that abuse. I certainly won't read this slide, but I've just included this slide if anyone would like to look at this in more detail. This again is a note on those conceptual models, and you can probably guess I'm kind of over-egging this pudding a little bit, but it's simply because this is such an important part of conducting any survey about child maltreatment prevalence or outcomes. The questions must be congruent with these types of conceptual models. If not, the data is likely to be compromised or limited. So we've spent an awful lot of time making sure that our questions are adequately framed. In terms of the second parameter, the health outcomes, I'll just talk briefly about the mental health outcomes. We're using a proven instrument called the MINI International Neuropsychiatric Interview, to obtain diagnostic information for 4 key mental health conditions. So we're looking at anxiety, PTSD, depression, and alcohol use disorder. We are also assessing physical health. So we're looking at obesity, cardiovascular disease, diabetes, and sexually transmitted infections. And in terms of adverse health behaviours, we're looking at tobacco use, alcohol use subclinical, substance use, self-harm, and suicidal thoughts and attempts. In terms of the third parameter, the burden of disease, so here we're trying to estimate the personal, community, and national costs of maltreatment. And this is quite a technical area, and fortunately we have 3 people on our team who are expert in this field and who've contributed to many global burden of disease studies that are published in the Lancet. And they can talk about this in a much more informed way than I can, but I'll just point to the fact that here we're assessing burden of disease that is attributable to health conditions which are related to child maltreatment, which is calculated based on our prevalence data and what's called the relative risks of disease. So here we're measuring or estimating years of life lost, years lived with disability, and disability adjusted life years. We're also using other parts of the National Survey of Mental Health and Wellbeing to gather data on health service use. So we're asking people about hospitalizations, medical and mental health consultations, and medication use. But just very briefly, I'll just mention that we've paid a lot of attention to making sure that our participants are safe and that they are appropriately cared for. So there's two parts to this aspect of the study. We've developed a distress protocol so that we can prevent and minimize and manage any participant distress, including risk of harm to themselves or to others. We should note that people often assume that surveys about child maltreatment can be traumatic, but in fact, studies that have been done overseas have found that people, even when they are answering in the positive to these questions, do not find such questions too distressing. And we actually built into our pilot a question at the end about how upsetting it had been to answer questions and whether people would be prepared or would have been prepared to answer the questions even if they knew ahead of time what they were. And we assessed levels of distress, and levels of distress were very low. People were happy to have participated, so we were very reassured about that. Nevertheless, it is important to protect participants to the greatest extent possible, and so we've gone to great lengths to do everything that's possibly done to do that. A second part of this, taking care of participant care and safety, involves a reporting or referral protocol. And here the purpose of this is to protect participants, especially youth, but also adults in some cases, who may be at imminent risk of abuse or harm. And this is actually an extremely complex area. And this as well has required us to do quite a lot of work to make sure that our approach is sound and ethical. And we've informed our approach here by analysis of legislative duties to report child maltreatment, other common law duties in the law of negligence towards research participants, ethical duties of researchers, and best practice in the international field. And so we've developed a detailed referral protocol here. It has primary application for 16 and 17-year-olds who are potentially at imminent risk of further abuse or significant harm by another person if they've told us that they have experienced physical or sexual abuse in the prior year. But it does have other applications as well. And we have devised this system for detailed management informed by a case-by-case risk assessment, taking into account a dozen different factors. There's no need for us to go through this here, but I've just included them there for completeness. In terms of the pilot performance, so we conducted this full pilot test in April and May this year. This had a strange kind of advantage in that it was conducted through our Social Research Centre interviewers under COVID-19 conditions. So they were actually at the time under lockdown, working from home, administering the survey from their home computers. So the way it works is that they phone a participant and they enter the participant's responses into the computer program and using its software that we've developed. So even there, it was a difficult process in terms of the kind of stress test under those conditions, but we were still very fortunate to see that everything, including the software, worked even when people were in their individual homes rather than the central call centre that the Social Research Centre normally uses. We were very gratified to see that all of our questions performed well. It also gave us useful information for final revisions to the instrument. So we did a retest of the maltreatment questions 4 weeks after the initial administration. Essentially, that's to see did people give the same responses to those questions the second time around? And that's to enable us to test reliability of those questions. We were pleased to see that the demographics from the pilot were sufficiently representative. There was very low missing data. The frequencies for questions were generally within expected ranges. And in terms of the statistical analysis of the maltreatment questions, we've conducted 5 different types of analysis. Some of those results indicated areas where we may usefully benefit from slight refinements, but by and large, overall, those analyses showed that our instrument performed exceptionally well, and that was a great relief to us all. We're working on a number of publications already, particularly about our methodology and about legal and ethical duties and conceptual models. Forthcoming work will involve a lot of engagement with members of our advisory board, and there may be some of you in attendance today. So I'll just mention briefly that as part of our governance framework, we have an advisory board, which is in a kind of constant process of gradual growth. And this includes representatives from multiple government and non-government agencies at national, state and territory level. Now, the reason we have this advisory board is partly to give us advice about the study, but also to advocate for our study and to inform our engagement with government and non-government agencies, especially in translating the outcomes from our research so that they can have the best possible chance of informing future developments in policy and practice. So this is something that we take extremely seriously and will be continuing to give more and more effort in relation to. It's very, very important. I'm sure Daryl would back me up on this. We do not want this just to be a very, very strong scientific study. We have just as much commitment to making sure that, to the greatest extent possible, we're able to have our scientific findings make a real productive contribution to health and other policy to better prevent and respond to child maltreatment in this country. So that's a very strong commitment that we have, and that commitment is present across the team, and that's something that we're continuing to invest our energies in. Daryl, did you want to say anything about that?
Sorry, I had myself on mute because I'm busily typing a few answers to some of the fantastic questions that are coming in, so please keep them going. But absolutely, I think the whole issue of the policy relevance of this study is really one of the things that excites me most about it. Data for its own sake is of much less relevance than data that's actionable, whether it's at the prevention, the early intervention, or the care and response side of things. All of those 3 areas need to be, I suppose, directed in terms of the knowledge that we have about the occurrence of harm and the factors that are associated with it. And clearly we don't have that information currently. And that was one of the reasons why it's probably worth mentioning. I know one of our questions has come in about, hasn't the Royal Commission, already given us information about the health outcomes? Well, in fact, this study was one of the recommendations from the Royal Commission because they recognised the gaps and the absences in the available data that we have.
Thanks, Daryl. Thanks. And I'm very glad you've been monitoring those questions, but we may have a little bit of time to come to those in a moment because I think I'm coming to the end here. I'll just mention a couple of limitations of our study, and every study in this field, no matter how well funded, how well designed, is always going to have some limitations. So for us, despite our best efforts, we do have some constraints on time and cost. So it's not possible for us to assess all mental health or all physical health and other outcomes. So we've had to make some strategic decisions there, and our team has worked very hard as a whole team in discussing this and drawing on all of our combined experience to figure out which things are most important for us to measure. There are some other outcomes that could potentially be considered, but the methodology would need to be different. So, for example, some studies can measure, say, educational outcomes, but they would be better done using other methods such as data linkage. A second limitation is that there may be some subpopulations in Australian society that are particularly hard to reach. And we've considered this at length in planning and design. So even, 3 years ago when we were putting the research proposal together, we were considering this at length as far back as that. It's quite likely, and we've been informed by advice from the Social Research Centre about this, who've done similar national studies before, that it is quite likely that the sample will naturally fall out so that we do actually obtain representative participation from certain groups. Where you don't, where the representation is slightly lower, then you tend to just use orthodox statistical measures such as weights and adjustments to accommodate that. However, there will be some subpopulations, such as those in detention, who will almost certainly not be adequately represented. And some of those groups, there's just no way around the conclusion that you would need a separate dedicated study to properly investigate their experiences. In terms of Indigenous Australians, again, our sample might naturally fall out to obtain sufficient participation. But here we tend to think that for a range of reasons, the ideal would be, and the best thing to do would be to do a separate dedicated study as well, which is tailored, which is customised to Indigenous Australians. And that would also mean, and rightly so, it would mean a much heavier involvement of Indigenous Australians, both on the research team, but also in partnership with community groups and strong community involvement. Nevertheless, we do hope that our study does capture information about the experience of these groups. In terms of future goals, I'll just mention that yes, we do have quite a few future goals as well as this benchmark study. So we would love to do prevalence studies in future with separate youth samples of those aged 16 to 24 so that we can track trends in maltreatment over time in Australia, so that we could also do further deeper analysis of specialised contemporary topics such as internet violence, and so that we could potentially consider the effects of policies and practices that are implemented on the experiences of future samples of Australian youth. Second, we would really love to do cohort studies looking at longitudinal effects. So it would be just magnificent to be able to consider mechanisms and pathways of impact over time, including through neurobiological research, to look at intergenerational trends, efficacy of interventions. That kind of work enables you to get much better evidence to try and break cycles of maltreatment. This is one of the most intractable problems in society, and it's these kinds of studies that can really help you to do that through identifying mechanisms and pathways of resilience over time. That's just a summary slide. I won't dwell on that, and some references there. And we may have a few minutes for questions. If Emma, if you would like us to do that, Emma and Deb, or we'll take your advice, we're happy to give written responses or...
That would, I know, thank you, Ben. Thank you, Daryl. That was so hard to get through that in the time that we allocated. Daryl is working through the questions, but I might just reference some of them. And you know, Denise Clare is prolific in terms of her questions. And I might just go to the ones that Daryl hasn't been able to get to. In regard to imminent risk of harm and abuse from cultural perspective, it is known that many cultures are taught to be silent about what occurs in their home. Appreciate knowing how information from coal populations has been obtained and the research is satisfied, adequate and accurate. Now this, you did reference the cohort issue. It will, I mean, we are you know, we would want to make sure that our Aboriginal and CALD communities are involved in this study. And that's come up a lot in the questions, actually. Ben, Daryl, we might want to talk a little bit about that.
Sure. So look, as we mentioned before, it's essential to this study that it is a random sample. So to an extent, the sample falls out how it does. So anyone who is called and is invited to participate, who has a mobile phone and who wishes to participate, will. There are no restrictions there other than the ability to comprehend English. So we don't administer the survey in other languages, that's for sure.
Yeah.
But it is pitched at, and we've tested the language level so that it's able to be understood by people, I think, at say, an age of around 10 or 11. So it's quite simple from that perspective. In terms of proportionality of participation of certain groups, again, there are certain limits to what we can do there. So we're first and foremost relying on the natural fallout. Again, in terms of the Indigenous participation, there's a number of issues there, and we probably can't accommodate all of them. So, for example, we do not necessarily, we can't necessarily guarantee proportionate representation of Indigenous Australians, say, from remote communities. And there's simply no way around that in this particular study. However, proving the robustness of our approach should at least lay the foundation for other connected studies to be conducted with such groups in future by teams, appropriately constituted and supported teams.
Yeah, thank you, Ben. I can hear you're really trying to reach into communities with this study, and I think that your comments about further studies, or at least being able to do repeat studies, I think is really so needed. We do have an anonymous one about cultural practices, taking into account that in the child maltreatment context, some parents and children may not see the situation as maltreatment. And you talked about congruence and definition. Do you want to talk about that a little bit? And it may see maltreatment as disciplinary actions within the culture. Neglect may also occur due to limited resources, particularly in large multicultural families, says this is this question. Would you like to respond to that?
Absolutely. Excellent question. And we do recognise that there can be legitimate cultural differences in some manifestations of what others call maltreatment. And so we've taken that very carefully into account. And this is something particularly to be mindful of in terms of neglect, but also emotional abuse. And neglect in terms of, say, poverty-related neglect is an important phenomenon that we need to accommodate, and we are and we will. Yeah. In terms of emotional abuse, there are some cultural practices that may need to be accommodated, say, in our interpretation of results. There's no doubt about that. We need to be culturally sensitive in both the development and design of the instrument and also interpretation of what we find. However, there nevertheless are some generally accepted fundamental positions about what types of activity and what types of interactions are damaging generally to kids across cultures. And it's important that we don't resile from that. So we need to be careful in not simply excusing certain behaviours simply on cultural grounds. Mind you, we need to be very careful and diplomatic and fair and reasonable in how we deal with different cultural practices and customs, that's for sure.
Thank you, Ben. I might ask one more question. It's come from Lisa about packaging up these resources so that they've been translated in a form that our service providers can utilise. Now, clearly, that's, you know, you're doing that today, which is sensational, and presumably you're going to keep doing that as the study evolves and you get your findings. I shouldn't put words in your mouth, but I know you, and I know that's what you want to do.
Absolutely. And I mean, Daryl and others on the team and myself are very, very strongly committed to having the, you know, whatever we can do in terms of useful knowledge translation and packaged usable products, we are absolutely going to do. So yes, we're going to have, you know, the traditional scientific journal articles and the big technical reports and so on, but we will be producing, I'm sure, dozens and dozens of usable briefings, policy notes, and nice graphically designed products that are aimed specifically at community groups and different kinds of service providers. Absolutely.
And anything we can do to help you translate that work, you know, Daryl knows we're also keen to help. So, and you know, you've been, we feel like we've been involved from the beginning of this, so I can say that. Now, we've still got other questions in the Q&A we won't get to, but I know you, Ben, and you, Daryl, we will get those answers back to people post this session, and people are obviously moving on to other things now. So I might just say, can we give you a virtual clap to say thank you so much. This is tough subject matter, really tough. But we shouldn't recoil away from it. And you used that language when you talked about culture and the way we see these issues. I think getting answers to some of these issues that affect our community very deeply and profoundly, and setting some foundations is going to be very exciting. And some of the comments on the chat are about how incredible this work is, and it's going to be in setting up our policies, our programs, and the way we do things into the future. So thank you so much, Ben. Thank you, Daryl, and we look forward to getting you on Zoom again soon as we progress through this work. Thank you.
Thank you very much. Now, I'll just say that we really appreciate everyone's interest. Please do feel free to get in touch with me or our project manager. We can add people to our email list so that they will get information about any things that we do produce. And we really look forward to presenting to you again.
Thank you, Ben. Thank you, Daryl. And we'll send the presentation out and all the links so you can make contact directly if you want to. Take care and have a good weekend and stay safe. Bye-bye, everybody.